Hello and welcome, everyone. I'm Dr. Tom Chaney, and this is Living Health Live. Joining me on the show, as well as in life and in our practice, Living Health Integrated Medicine, is my wife, Dr. Stephanie Chaney. We are your trusted source to the latest information to help you get and stay healthy naturally. We're super excited to be joining you regularly to take you on an adventure of a lifetime, your lifetime of great health. You're going to get great information, health strategies, and the latest research on how to live a better and healthier life. Just remember that the information on this show is intended for educational and informational use only. The information given here is designed to help you make informed decisions about your health and is not intended as a substitute for medical treatment. So in today's episode, we are going to do a case study. This case study is a type 2 diabetes, and it's diabetes reversal in just 6 months. So, Dr. Steph, let's start with the case history on this patient that came into us.
Okay, so this is a 63-year-old male, and his case summary is that he came to us. He has been diagnosed with diabetes in 2010. Metformin, a statin, cholesterol medication, blood pressure medication. He had frequent urination, fatigue. He was only sleeping about 4 hours a night. And since his diagnosis in 2010, he's been experiencing also the neuropathy, tingling, numbness, decreased balance, muscle cramping, and then has an issue with concentration. He's very concerned about the potential for dementia. I think it kind of runs in his family. And his hemoglobin A1C before he started with us, about 3 or so months before he started with us, was apparently 6.1. But you'll see when we took his initial blood work that it was significantly higher than that. And so his goals were to reduce his A1C, get it into the 5s, non-diabetic range, be able to eventually stop metformin, lose 40 pounds. And his starting weight was 244 pounds in the office. And then be able to get back to enjoying life. Basically, he had this list of things that he wanted to do, places to visit, travel, things like that. So very high motivation to reverse his diabetes. And so that's his case. That's his initial history, basically.
All right. And you can hear from that history that diabetes, it's affecting so many different parts of his body. So neuropathy, so it's affecting the nerves. He's concerned about his brain health.
And we know that if you have numbness and tingling, neuropathy in the feet, that within 5 to 7 years, it's not uncommon to start getting into the hands. And then eventually, if you have neuropathy in the feet, you will have degradation of brain. It's all kind of part of that inflammatory kind of cascade. And this case had a lot of inflammation coming to us.
All right, well, let's dig into the numbers. All right, so I'm just going to enlarge this a little bit.
Make us tiny.
There we go. So this is an internal spreadsheet from our office. That's what you're looking at. So those of you that are seeing a video of this, you can see that there are names on the left-hand side. These are all the markers that we ran. We've got
Dr.
ranges.
Tom, can you make this bigger?
Oh, let me see.
Yeah, there we go.
How's that?
Much better. It's just hard to see.
Got it. Okay. So this is an internal spreadsheet from our office. So like I was saying, the left-hand side, these are all the names of the markers that we ran. We have functional range, and Dr. Stess, maybe you can compare functional range versus laboratory ranges.
Yeah. So all of these numbers, these are from LabCorp. So we send the patient to LabCorp and have the blood work done. When we get the results back, we log their results so that we're comparing their results not just to LabCorp's ranges, but to also functional ranges. So the labs, like the major labs, many ranges for many markers are simply an average of what walks into the labs every year for blood work. And it's kind of like a bell curve sort of situation, right? So because of that, many markers, the major labs are not clinical decision makers necessarily, right? So they're just creating these averages. Most of the people going in to get routine, regular, frequent blood work are dealing with some kind of illness and are takers of lots of medications. So those are not necessarily ranges of healthy people per se. And so we use what we call the functional range. And depending on the marker, these ranges could be whatever's been found in research to be ideal for optimal function, not just to prevent an actual out and out disease deficiency. So that's kind of what we're looking at here. So these are tighter ranges usually. These are ranges where if you are going outside, like you're functionally high versus lab high or low, these are indicators up to us of things that are coming down the pike. So you may not have an out and out diagnosed issue, but we're catching things early. So our goal is to be proactive, preventative. And we also look for patterns in blood work too. So we can talk about that as we're going through this case.
Okay. All right. The other thing to just to kind of understand is that not all lab work is created equal. We have patients bring in their lab work that they've had run by their doctor, and a lot of times they think that it's very thorough when actually it's not. So you're going to see markers on this test that a lot of times they're not included in routine lab work. So why don't we start at the top, Dr. Steph, and we'll just work our way down. We'll start with the first test, number 1, and that was in August of 2024.
Sure. Okay, so if we look over to the left column, we see hemoglobin A1C and glucose at the top. So this patient was on metformin with a goal to obviously reduce it and eventually eliminate it. Hemoglobin A1C was actually 7.4, which is in diabetes range. So diabetes is 6.4 or higher. Prediabetes is considered 5.7 or higher. So our functional range for that is 4.8 to 5.7. Hemoglobin A1C is a percentage of red blood cells that are damaged. And there are other things aside from blood sugar that can damage red blood cells, but sugar is a big offender to red blood cells. Okay. So he started in August with a 7.4. And when we tested him for, the goal is not just to see what his hemoglobin A1C is in the beginning, but to try to determine the contributing factors, right? Diet, food. But we also ran some organic acid urine testing and found very high yeast and fungal markers. So that's very common when people have high sugars. They're also creating dysbiosis and feeding yeast and fungus. So then yeast and fungus gets higher. That causes inflammation. Your immune system is being hyperactivated. And that inflammation can also now cause sugars to be higher. So it becomes these vicious cycles of metabolic stress, infection, overgrowth, all these different things. And this is how a diabetic case can just get out of control over the years, right? So with medication, he was started at 7.4 and he was on a cholesterol lowering medication and his total cholesterol is 167. I don't really concern myself, honestly, too much with cholesterol, but you can see here that his triglycerides were elevated per hour range. And triglycerides are another diabetes marker. So triglycerides are an indication of insulin resistance. So if you cannot get sugar, for example, into muscle and tissues that we want it to be in, and blood sugars are high, then what happens is the liver starts to try to package that sugar up into a glyceride form that will then be stored as fat. And this is the underlying main contributor to fatty liver disease, which usually starts well before even a person is diagnosed with diabetes. But ultimately, this is a sign of insulin resistance. So you can see here that over the course of August to November, we were able to help him get his sugars down and his hemoglobin A1C down just over a whole point. So 7.4 down to 6.3. And cholesterol came down 167 to 138, which is actually low for us. We recommend that cholesterol stay around 150 to 200. Cholesterol is the base molecule for manufacturing all your hormones. It's a major transport necessity to get healthy fats to brain and nerve tissue. And so once again, this is a patient with neuropathy and a concern for dementia. And it's also the base molecule for all your hormones and making your own vitamin D. So super important to actually maintain optimum levels and not get too low. Within that time period, August to November, his triglycerides came down from 117 to 88. So now we know that we are experiencing less insulin resistance and his tissues are becoming more sensitized. So he's better utilizing blood sugar. And his LDL, quote unquote, bad cholesterol, I hate using that term, but that's what people understand, came down from 97 to 83. Now, he did also have a drop in the HDL from 49 to 38, and that's the quote unquote good cholesterol. So at this point, it's when we recommend patients go back to their prescribing physician to have their statins reduced or possibly eliminated so that we can maintain optimal levels of good cholesterol and hormones and general overall nerve and brain function. And then by February of this year, his hemoglobin A1C is now down to 5.7. And the update back in, January, his primary had reversed, so had reduced his metformin by half. So now he's on half the dose of metformin as of January, and he's continuing to improve. So obviously the next coming few months, the goal is for him to be maintaining this or improving further, and then eventually being able to see how he does without metformin at all. And his cholesterol is now normalizing a little bit better. So he's coming up to 145. Triglycerides are still coming down, which is good. That's what we want to see. And his HDL is now coming up. So the cardiovascular risk marker, which is the total cholesterol over HDL, has now come into normal range, which is more looking at the balance of the cholesterol. That's the big takeaway from, obviously, with the goal of reversing diabetes. These are key markers to look at. So maybe we could go to the next.
Yeah. So like you said, you want to look and dig a little deeper to figure out actually what's causing this and what do we need to work on.
And how did we do this? So as we go through the rest of the blood work, we'll talk about how we targeted this case to get the reversal. Okay, so white blood cells were elevated. White blood cells being high is an indication of acute infection. And what was really high and completely out of balance was neutrophils. Now, neutrophils, lymphocytes, monocytes, eosinophils, basophils, that list on the far left there of the breakdown of different types of white blood cells. These white blood cells all have different duties and are responsible for handling different types of issues that come into the body. Neutrophils will be elevated when you are dealing with yeast, fungus, bacterial infections. Lymphocytes will be elevated when you're dealing more with viral. The ratios between neutrophils and lymphocytes should be about 2-1. And you can see here that he had 86% of his white blood cells when he came in was neutrophils, and his lymphocytes were actually very low. And this is a huge indicator for some type of yeast and fungal bacterial infection. And when we did his organic acid urine test, he came back with very high fungal markers that were indicating an overgrowth of yeast and fungus in his intestines and throughout the body. So this was going to be a contributing factor that we would have to deal with. So it wasn't going to be just changing the diet and giving him good pancreas support supplements. This was going to be a situation where we had to actually get these fungal markers down and kill the yeast off that had started to overgrow. So you can see as we go through, white blood cells went from a high of 8.1 down to 5.5, and they actually calmed all the way down to 4.8 the last time we tested. And now he's in a much better balance between neutrophils and lymphocytes. It's went from 72 to 20, and then now back in February, 64 to 27. So that's looking much better. Liver enzymes improved. He actually on paper did not really have any really lab high liver values, very mild functional high, but everything's normalized and well within functional ranges for that. And then there's one marker at the bottom, anion gap, which is a calculation of the balance with sodium, potassium chloride, carbon dioxide. And if it's high, above 12, that's an indication of high systemic acidity. and we want to be more alkaline. And so you can see here that he's coming down into a more alkaline state as far as blood alkalinity goes. So then if we look at the next page.
So getting that more alkaline is going to be his diet, and then also
Killing
with
infections.
these overgrowths. Good. All right, next page. Now we're looking at kidney function at the top.
Yeah, so kidney markers, again, nothing really crazy. There was a period of time when we were doing a lot of liver work and a lot of killing of yeast. That puts a little bit of stress on liver and kidneys because the body has to eliminate all these basically, dead critters that we're handling. So right now his kidneys look good. His kidney enzymes are normal, and that's BUN and creatinine, and his filtration rate is up around 76%. The metabolic inflammation markers are mind-blowingly high. So I'm going to go through these because these are not commonly run by most doctors, and these are looked at for sure by us. And so one of those is CRP. That's C-reactive protein. So it's near the bottom of the column. And underneath that is homocysteine. And underneath that is fibrinogen. So C-reactive protein is a non-specific indication of tissue damage and acute metabolic inflammation. He came in, it should be, by the way, as close to 0 as possible, but our range is 0 to 3. And it is both all C-reactive protein, homocysteine, fibrinogen. These are markers that indicate damage against brain, nerve, and cardiovascular tissue. So arteries, these are cardiovascular risk markers. These are more indicative of someone on the verge of having a stroke or a cardiac event or a brain event than cholesterol levels. So he started at the C-reactive protein of 38.91.
Wow.
Very crazy high. And no one had measured this with him before. So between that, when we see double-digit high C-reactive protein, we're usually thinking major infection, right? And then his white blood cells were also indicating like he was just overgrown with yeast, which is just a huge contributing factor to all kinds of issues. Homocysteine is a byproduct of cellular function. So it's a waste product, right? Cells will run their motors and machines, making energy and doing their processes, and then they just dump waste right outside themselves. And that all goes back to the liver, and the liver has to process this out. And this is something that gets excreted through the kidneys. It's very damaging to brain, nerve, and blood tissue, blood vessels. And we do not like it to see it above 7. We definitely don't like to see double digits. The lab range for this is they don't want to see it higher than 15. And he came in with 43.5. It might be one of the highest homocysteines we've ever seen. So was he right to be concerned about dementia? Yeah, very much so. And when we see things that high, these are definite indicators of a higher need for methylated forms of B12 and B9 methylfolate. These are really important vitamins that the liver needs to safely and effectively and eliminate these metabolic waste markers. And then fibrinogen came in high. Fibrinogen is a sign that he's got damaged tissues and the body is creating this fibrous material like clotting. Not much different than if you cut yourself and your body has to lay down protein to try to heal. When you have systemic inflammation, this can infiltrate, this can be in circulation. This is a sign of clotting in the bloodstream. So when we talk about blood clots and stroke and things like that, we don't want to see this being high. And we standardly run this on all of our patients. So by his November, so from August to November, his C-reactive protein came down from 38.91 to 6, which is a huge decrease. So we're immediately, this is proof that we're handling the right triggers with handling the yeast, fungal markers, the diet, and all the things that we did for him. And homocysteine's coming down now from 43.5, which is just crazy, to 16.6. Now, if a patient came in with 16.6, that's high. Like we're still working on that. One of the things that people don't realize is that over time, metformin actually causes a decrease of B12 in the body. and you become deficient in that. And so this is probably a patient that had genetic issues with methylation already and had higher requirements for B12, and then had been on metformin so long that was becoming more and more deficient. And this was what was contributing to this progressive inflammation against brain and nerve tissue and cardiovascular tissue. And then fibrinogen, one of the ways that we lower that, one of the only effective ways, aside from getting tissue healing that helps bind and clear this and break this stuff down, is nattokinase. So our supplement nattozyme is critically important for this as well. So this is where we get into targeting specific nutrients. So if someone's got really high C-reactive protein, when it's that high, we're handling infections, underlying pathogens, parasites, yeast, fungus, whatever we test for. Mold in the environment could also be a factor. And then we are going to supplement with higher doses of vitamin C and CoQ10 and certain things that help bring this marker down. When homocysteine is very elevated like this, we make sure that we supplement with therapeutic dosing of our methylation plex, which is a combination of B12, B6, B9, and some other cofactors that actually support the liver getting rid of this safely through the kidneys. And then we may tinker with how much of B9 and B12 that we give to someone. And then, so you can see how like we're creating an individualized targeted supplement protocol based on what we actually see as screaming at us in his blood work. But this is great progress for this kind of case, and the severity of the things that he had going on contributing to his elevated.
Now, one of the things you mentioned is that like CRP, C-reactive protein, homocysteine, fibrinogen, many times in conventional workup and lab testing, they don't even run these. So I think the audience is probably asking, well, why the heck isn't my doctor running these? And, one of the reasons is because
insurance doesn't cover them.
Well, not just
that's a huge factor.
But even if they do run them, there's no medication to drive homocysteine down.
Right.
Right.
And that's why insurance doesn't cover it, because there's nothing really, there's no treatment, there's no conventional treatment, there's no like intervention. So there's no reason, it's like not medically necessary from a medication perspective. And so, yeah. But this is why we run cash panels, because the cash panels give us all of the data that we need to make sure that we're targeting very specifically the patient's needs. You know what I mean?
Yeah. So the house is burning down and this guy's
right.
Like, if you look inside his body, like it's on fire, right? So
yeah,
you would never know that if you just ran conventional testing. They would
Yeah.
just look at A1C and say, okay, you need more metformin, or we need to add another medication.
Yep. And then, we correlate this type of testing, and we didn't put his organic acid testing up. It would have been interesting to do that, but his urine metabolic markers also showed deficiencies in B12. So obviously between homocysteine being super crazy high, and then his mitochondrial markers were all really off the charts. Mitochondria are the part of the cell that actually make the ATP. They make the cell's energy. The mitochondria need B vitamins, especially B2, B6, B9, B12, to make energy, along with oxygen and vitamin C and CoQ10. All of these are factors in the cell at the mitochondrial level, just making energy. So, chronic fatigue. I was low in vitamin C. He was low in CoQ10. He was low in B12. And we can see that represented here on the blood work, showing that he was low long enough that his blood work was showing like he was on the verge of having a heart attack or stroke. And yeah, that would have totally been, this is totally missed. Like, this is just not, they just run hemoglobin A1C, they run lipid panels, and they medicate for those markers. And they're missing this whole inflammatory situation underneath the hood. And like, honestly, thank God he found us when he did, because these markers are crazy. Oh, I just lost your volume. Can't hear. Can you hear me? I can't hear you. Do you want me to wrap it up? Nope. Can't hear you. Okay, let's wrap this one up because we're about 27 minutes in anyways. And hopefully when we do the playback, we can at least hear me. So basically, in summary, this is an amazing case to demonstrate how important it is to get complete blood markers, run full functional panels, along with some of the other testing that we do. So we're handling all the different contributing factors and causes for the blood sugar being high. It's not just diet with this guy. The metabolic imbalances got so far out of control that the metabolic stress was also now contributing to elevated sugars and insulin resistance, and then underlying infections for this guy, overgrowth of yeast and fungus and mold. And so our goal in the next few months is for this guy's hemoglobin A1C to be down even lower, be able to come off metformin and continue supplementing strategically because he still needs it for these other inflammation metabolic markers to support his body is literally healing itself right now from major damage to his brain, nervous system, and cardiovascular system. So I'm not sure what happened with Dr. Tom's sound. Still can't hear you. But we're going to sign off for now. And we get really excited about these kinds of cases. You know, I oversee and supervise our functional nutritionist, Carla. Carla really works hard with these patients, implementing the food plan, implementing the supplements, and we collaborate on all of these cases. And so we get super excited when we have patients that are compliant, that do the work, because obviously it does take work. We can tell you what to do, but you got to go home and day in and day out, you got to do the work to reverse decades of damage to the body. So kudos to this patient and kudos to our team, because it is definitely a team effort. And this is the stuff that we live for. It gets us super excited. So we're going to start presenting cases more regularly so that people can actually see some of the amazing successes that you can have if you buckle down and get to the right sources of people's illness. So signing off for now, and we'll be presenting another case and we'll get our volume figured out and our sound figured out. And there's always something that happens. All right, guys.